Alright, hey guys, today we're gonna go over stage 1, lipedema liposuction, LippyLipo, and our patient here, we've done her the beginning of October, and that's how she was on stage 1, and this is her. We did 2 sessions on her, lower legs 360, and then we did 360 degrees LippyLipo to the thighs upper. And here what I'm gonna write your questions below so we can get started. I have a bunch of questions here that we've been getting on Insta, and what we do is we answer all those questions on Monday. So first, let me tell you a little bit about this patient. She's 54, came to us with stage 1 lipedema. As you can see, most people who look at that say, you know what, these are normal legs. They cannot see the lipedema because she's very early in the process. However, when you look at her, you see the fullness on the inner knees and this fullness on the outer knees. Kind of like that's how usually lipedema starts. It sits all the way around. On her, she has normal ankles, but she starts at the calf and it goes all the way up. She does have that fat pad that sits kind of like on top of the shin area. Again, she's done a great job to be at this shape at 54. She's athletic, she works out a lot, she takes care of her diet, and she was able to keep her lipedema at bay. So on her, we did 2 sessions. We did 1 session on Tuesday and 1 session on Thursday. The Tuesday session was 360 LippyLipo from the knees all the way down. We took out 2.4 liters on her, and the Thursday session, we took out 3 liters. We did her thighs. As you can see the muscle, the quad muscles on her, really narrowed her knees on both sides, and you can see the bruising from the session that was done on Tuesday. So again, like impressive, great outcome, nice and smooth, fully awake for the procedure. She was able to walk out with a big smile on her face. She lived with it for like 50 plus years, and looking this way, I mean, she was like unbelievable. You can see the light reflex here, and I mean, she looked awesome. Again, and I think, let me show you, I think I have a picture of her back as well. Just kind of, so at least you get an idea of how things look on the front and how things look on the back. This is how she looked on the back. You see kind of on the back, you see more of her lipedema fat cells. And if you want to take a look here, lipedema here, also inner knee, goes all the way up. You see kind of touching on the inner thighs there. And the thing with lipedema, it's like, it's 360 degree fashion. The fat sits in a 360. It's not like regular liposuction or regular lipedema fat, where the front, you have the front, you have the back. So it sits all the way around the extremity. So you see it on the anterior thigh, inner thigh, posterior thighs, on the back of the thighs. You see it on that knee area, kind of behind the knee, and definitely in the calf. On her, she didn't go all the way down to the ankle. Most patients with lipedema, they would go all the way down to the ankle. But there's multiple types. It's like type 1 or type 2. They kind of like type 2 stops here. Type 1 is usually that kind of that we call it the tire, kind of that sits around that upper buttock area. Type 3 goes all the way down. Type 4, you've got involvement of the arms. And this is her result. Again, like perfect. You see tiny knees, nice and smooth. The ankle, the calf going all the way down to the ankle looks great. You see the Achilles tendon, nice and smooth, went all the way up to the inner thigh and outer thigh. I mean, she looks awesome here. So I see like a few questions here. Let's kind of go over them, and then I'll go over the other questions. Carol is asking, do you have any experience or recommendations for people with lipedema and lymphedema? Great question. So lipedema, you can have stage 1, stage 2, stage 3, stage 4. When you get to stage 4, it's usually lipedema and lymphedema. You get both. Stage 3 is when you start, the heaviness of the lipedema fat starts obstructing the lymphatics. When lipedema obstructs the lymphatics, then it pushes that patient into developing lymphedema. So basically, you go from lipedema, from one problem to now having 2 problems. Now you will have lipedema and lymphedema. The treatment for those patients who kind of advance to stage 4 is actually LippyLipo. It's liposuction getting out that lipedema fat cells, so it minimizes the obstruction on that lymphatics, so the lymphatic outflow kind of to go back to the heart, it's not obstructed anymore, so kind of the flow is better. So the treatment is the same. Now, if somebody has only lymphedema, which is like only one leg that's large and you have lymphedema there and the other leg is normal, the treatment is different. It can be like a bypass or liposuction plus or bypass. It's something that we don't do here. We only treat lipedema with lymphedema or lipedema alone, not lymphedema by itself. So, but that's great questions, and that's what I tell patients. You gotta attack it early on, because if you don't, we know lipedema starts at puberty, and then it gets worse with pregnancies, right? With every pregnancy, lipedema tends to get worse. And then menopause really push things forward. So the sooner you treat it, the less the chances of progression later on. So it's very important, especially if somebody is around menopause or kind of like in those like late 40s, 50s, kind of 40 to 60, I would say, you gotta attack it sooner. And if you're younger and you haven't had kids, you wanna also attack it before it progresses. Because when you go to stage 4, then now you're gonna need multiple sessions, because probably you have more than 5 liters. And the skin is not gonna redrape like our patient here. If you look here, her skin did great. I mean, like perfect. And here we don't use, like there's so many things on the market, this and you don't need it. If you do a great liposuction, you don't take the risks of using the other stuff and getting a great outcome with good skin redraping. It's the technique that really makes a big difference here. Good question, Carol. So we'll keep going back here. Thank you, you're welcome. So if I want to have children, should you get LippyLipo before having kids, or will you have to have it again after kids? Great question. Have it before having kids, because once you get your lipedema fat cells out, the chances of recurrence is like less than 1%. We actually haven't seen it. And regrowth and all that stuff, it's like so minimal. So if you can do it before having kids, or before menopause, or before like people who have like GYN surgery or major stresses, you wanna attack it at that point. So definitely you wanna have it before having kids. And I think the other question you have here is, will you have to have it again after kids? So I guess the question here is, what are the chances of recurrence or lipedema coming back in the same area, or lipedema coming back into other areas? We got that question all the time. We haven't seen, like, let's say this patient came to us, treated her, came back this way. We haven't seen patients coming back to us with lipedema coming back into the same area that was treated. We just don't see it. And I think part of the reason, once you clean that area, you're not gonna have somebody who comes in stage 1 and then come back like a few years later stage 3. We don't see it. I mean, is it zero? Nothing in medicine is zero, but we've done hundreds and hundreds and hundreds of these cases, and we just haven't seen it. So I tell patients it's not zero, but it's less than 1%. It's very, very rare. The other question we get asked is, will it come or will it go to other places? With those lipedema cells, can they go to other places? Again, we haven't seen it. That being said though, let's say patient has type 4, meaning they have lipedema in the arms and they have it in the legs. And we treat their lipedema in the legs. We didn't treat the lipedema in the arms. And then a few years later, let's say they go through menopause and their lipedema is flaring, and they would flare in the arms, they wouldn't flare in the legs because the legs have been treated. And then the question is, could the treatment in the legs have led to a flaring in the arms? And the answer is unlikely. Patients are gonna get advanced through menopause. If they haven't treated the legs, probably they would have advanced on the arms and the legs. But the fact that the legs were treated, now the arms are advancing because they're going through menopause, because lipedema fat cells, the way they react to the hormones around menopause, they kind of advance in stages. So we've seen that. So I always tell patients, treat it, get done with it. do the legs, do the arms, and if you have it around kind of the waist area, just get done with it, because the chances of advancing is much less. And that leads us to the chances, not only we're talking cosmetic is better, you get a better outcome with early treatment. In terms of amount of surgeries, you will need much less procedures if you treat it at stage 1. Like our patient, she's done 2 procedures, she's done. So you will need much less surgeries when you do it early on. The most important benefit is the functional improvement. Because patients, especially when they get around menopause and kind of later on, and if they are advancing in their lipedema stages, they start having pain, heaviness, knee issues, knee pain. The knee joints start to get affected. So it affects their lifestyle, it affects their mobility. And when that happens, patients will start looking into knee replacement, affecting their personal lifestyle, and they really kind of go on a kind of like downhill, especially after menopause. So to minimize the chances of that happening, you gotta treat it early. It's been like a game changer for our patients when we treat them earlier in the process. Good questions here. Let's keep on going down that list as we go in here. One of the questions is regular lipo versus LippyLipo, and can you do regular liposuction on the legs? Unfortunately, we do get patients who had regular lipo done by somebody else, and they come for us for second opinion or the revision or that. And we've been very selective on our patients. Most of the times, if somebody has been treated by other physicians, we just don't, because it makes the procedure much harder. But to help patients out, let me go back to the previous picture, because that show it. Most regular lipo, what they do is they would usually treat the inner knees and the inner thighs, and maybe on top of the anterior knee. So they will go get regular liposuction. They would liposuction that area. Sometimes they liposuction that area, and they would liposuction this area. That's what regular liposuction does. Different technique. Goes to somebody who doesn't know much about lipedema and doesn't do lipedema much. That's what they get their liposuction. The issue with that is when they treat those areas, this big part, the lipedema sits in the anterior thighs, it sits in the outer knee, it sits on the back of the thighs, and lipedema affects the extremity all the way around, 360 degrees. And if liposuction is not done 360 degrees, and if it's not down deep to the ankle, that's where problems start to happen, because we call that spot treatment. When they're getting regular lipo, they're getting spot treatment. So they treat certain spots, and now patients end up with contour irregularities, because now it looks like it's like a shark attack, kind of like one area kind of like being over harvested, okay? And that's residual lipedema fat cells. So even though the cosmetic outcome might be good originally when the procedure is done, as patients advance in life, the area around it is going to advance, but the area that was liposuctioned will not get advanced because the lipedema fat cells are removed, and now patients, they look deformed because the area was not treated 360 degree fashion. So this is like very, very important that really you want to treat it in a 360 degree fashion so that you don't end up looking deformed, especially as regular lipedema progresses through life. USA is asking, hi, I have lipedema in my legs and in my bottom. I got partial liposuction, and that's what we're talking about, spot liposuction, on my saddlebags and on the upper part of my buttock. I was so happy, but now I'm in menopause and the fat is back. I mean, that's a great, we were just talking about that. And that's why you gotta make sure you go to somebody who knows what they're doing. And they might know, that surgeon might know what they're doing in terms of regular non-lipedema patients. But when it comes to lipedema, you gotta make sure you go to an expert. Because like In your case here, you had partial lipo or kind of spot lipo in one area. As you go through menopause, the area that was not treated, it's gonna flare, right? And that's what normally happens to lipedema cells. Now you're gonna look deformed because the area that was treated, it's not gonna expand, it's gonna advance as the area that's not treated. So the take-home message here is you gotta make sure whether the buttock area or the lower back and the love handles or the thigh, you gotta make sure you treat them in a 360 degrees fashion. So if your lipedema is advancing in the future, there is no chance. You don't want to do spot treatment in patients with lipedema. Because when you do spot treatments, now you have scar tissue in that area. When you have scar tissue in that area and you go back to the same area, it makes it much harder to treat and much harder to get that nice silhouette and nice sculpting where you're transitioning from a non-lipedema area to a lipedema area and then to a non-lipedema area. So you gotta make sure you treat 360-degree fashion above and below so the end result looks harmonious and you get the best functional outcome, because we know lipedema affects the lower limbs or the upper extremities in a 360-degree fashion. Great point. Carol is asking here, is the reason because I just had partial lipo and not LippyLipo all around? That would be my guess. Again, I've seen it. I can't tell you how many times I've seen it, especially in lower legs where people have had regular lipo done to the inner knees and sometimes above the knees or the inner thighs, and these are patients who have lipedema. Patients didn't know. They go to a surgeon who doesn't know about lipedema, and patients will say, hey, can you liposuction my inner knees and kind of my inner thighs? It bothers me, because they're being bothered, but they don't know about lipedema. They go to the surgeon doesn't know about lipedema. I'm like, oh yeah, it's easy, I can liposuction the inner knees, I can so they do that. Originally patients like, okay, it's the result that I want, but not really, but it's better. So they get like that 50-60% improvement. But what happens is few years later, patients start having the other area that's not treated kind of advance as normal lipedema advancement, and now they become deformed. And that's when they come to see us. And now more and more are patients like you where they watch the lives or talking to groups on lipedema, and there's more knowledge among patients about lipedema and what's the right treatment. The other question we have here is, are there specific criteria I should track, document to get doctor or insurance coverage for LippyLipo? That's a great question. Our practice is not in network with insurance. That being said, there are certain places they are in network with insurance, and they would have like certain criteria that you would have to follow. I guess it depends on the insurance carrier. It will depend on the physician practice. My advice to you is, if you're gonna go down the route of insurance, and some people have to, they just don't have the resources to go the non-insurance way, make sure you do your homework and select the person that's gonna give you the best results possible, and somebody where you would feel they really understand what they're doing. What you wanna look for is somebody who's doing, like in our practice, is we do one case a day. That's it. Because these cases, to get these amazing results, it takes us 4 to 6 hours per patient. So that's a lot of time. So if somebody is doing like, I would ask them how many cases you're doing a day. If they tell you we're doing 2, 3, 4, be careful, because you're not gonna get an amazing result just because it's volume over quality. So you really make sure. And then the other question that you wanna ask, what other procedures do you do? If they do like legs, they do face, they do they do like other stuff, breast, tummies, then I would be, it's like they might be okay, but you won't get these results, because it's very hard to do an amazing job by doing so many things, because the learning curve is very hard with lipedema. So like in our practice, we don't do anything else. All what we do is just lipedema, and we do one case a day. And by doing that, we're able to accomplish these results. So definitely ask those questions and look at tons of that before and afters, and tons of patients' testimonials. And these are kind of like main questions that you ask and see. Because if they do like so many things, the odds of getting you amazing results on lipedema significantly goes down. And if they do so many cases during the day, also the odds of going, because if you think about it, to do her case, right? You gotta numb the front of the leg, then go numb the other front, then ask the patient to go on her stomach, then we numb the back, and then we numb the back. And that numbing part, it takes at least an hour and a half to do if you want to do it in a gentle way at low speed so the patient's having a great experience during the numbing. Then you're going to ask the patient to go back on her back and then start doing the liposuction here with tiny little micro cannulas so that you're able to get these amazing results. You got a liposuction here, and that takes about half an hour to 45 minutes, and then liposuction here, same half an hour to 45 minutes, and then have the patient flip and then do the same on the back, and that process takes about 5 to 6 hours to do to give great experience and great results. And if you're doing that, you cannot do more than 1 case a day, and that's how we can end up doing just 1 case a day, because we needed to be consistent on the results and on the outcome and on the experience of the patient. So if we want to do like 4 cases of that, then you will be operating 24 hours a day. And that doesn't work, because then you have fatigue of the surgeon, mental fatigue, physical fatigue, and then the results, you start cutting corners. But if you're doing 1 case a day, you come in refreshed, you give the best you can. There's a lot of passion and love to get these results consistently. And then I feel like after 6 hours of being like intense in it, that's it. You just, the brain is not ready to do another 6 hours of that. And that's kind of where the quality starts to go down. So I'll be very careful about that aspect. Kayla is asking, the fat under the glutes, banana roll, is it lipedema? Good question. It can be lipedema. Let me see if this, let me see kind of if the back here, it doesn't show it, but probably, so for the audience, the banana roll area is this area here. Let's say this is the buttock. It's usually kind of like, it's probably that area here. We call that banana roll area. This area is very crucial. Most mistakes happen is you want to liposuction this area, but you don't want to over liposuction this area. And I'll tell you why. If all the banana roll area is liposuctioned, what happens, the buttock will drop. You will have a buttock collapse. It looks like an 80-year-old lady with a buttock who's totally deflated, because the banana roll is actually supporting the buttock to where it needs to be. And over liposuction here, it will cause contour irregularities. Now that being said, we liposuction the banana roll all the time, but we're very smart about what part of the banana roll to liposuction, which area, and how much to push it. Like, I want to maintain the support of the buttock to keep it where it needs to be, because you want to maintain the shape, but at the same time you want to take as much lipedema fat cells out. So the key to a great banana roll area liposuction is definitely you want to clean the inner thighs, as you look here. I wish I didn't have that. You want to, like, all the inner thigh here needs to be removed, liposuctioned. Saddlebag area needs to be liposuction, and then you feather in towards the banana roll so that the shape, you have a great shape, but you still leave enough of that upper aspect of the posterior thigh to kind of keep supporting the buttock and keeping it at a good place. And most of the time what I'm doing at the same time, or at the third session, is treating the upper buttock, because most people, they have lipedema, they have the type 1, kind of that tire around. That tire is pushing down on the buttock. So you want to take that out so that nothing is pushing out. Keep part of that banana roll to have the support, and now you have actually the buttock would actually lift up when you take the weight from the waist instead of that pushing down on the buttock. So it's very artistic to be able, it's like artistic and math at the same time, and I love that, because it really took me a while to really understand the interrelationship between the waist and the upper thigh area, the saddlebag, the inner thigh, and the buttock, and how all elements kind of like go hand in hand. and it's actually they're all interconnected. You cannot over treat one area and under treat another area. You'll have the shape would look odd, and also you don't want to under treat a lipedema area. So it's actually very complex, but when you see it all in one element, you'll be able to provide a consistent, great result every single time. Excellent question here, Carol. Okay, let's keep on going down the questions. USA, Claudia is asking, would you recommend just do the liposuction on the leg or also on the bottom? I think we just answered that. I think any area you have lipedema, you gotta treat it. So definitely legs. I would start, most of the times we're starting lower legs, then thighs, and then we finish kind of with that tire effect, kind of 360 lipo around the trunk, down to the buttock. You wanna transition the buttock. You don't wanna actually liposuction the actual buttock, because liposuctioning the buttock itself, not the upper, like the middle of the buttock, will cause deflation and collapse, and that would look really bad. So in certain occasions, we've done it on patients who have overgrowth just in the buttock, but we're very careful, because you don't want to take one problem and switch it to another problem. So we have to be careful, like the solution we're creating to that problem is not creating a third problem. So it's kind of like we gotta be careful about that. Carol Mann is asking, if I'm considered overweight, do I need to lose as much as I can before surgery? Or is it better to get the lipo sooner rather than later? Great question. Weight or BMI and lipedema, they're kind of, in a way, to me, they're unrelated. Because most patients who have lipedema, their BMI is high or higher than it should be. And the reason for that is the lipedema fat cells, they are heavy. So even though the patient is losing as much weight as possible, they get to a point they cannot push it any further just because of the lipedema fat cells. So most patients with lipedema, they have a falsely elevated BMI. So in our practice, we don't look at BMI in terms of whether a candidate or not candidate for surgery. We do use it in terms of how many sessions the patients might need. For example, if somebody's BMI, let's say, is 40 plus, you know they're gonna need more sessions than somebody who has a BMI around 30. So kind of like it gives us an idea of how many sessions we might need, but it's not like a criteria where some practices, including us originally when we started, because we were doing under general anesthesia, let's say if your BMI is more than 35, you're not a candidate because it makes your risk higher from an anesthesia standpoint, which is correct. But since we evolved to awake LippyLipo, where there's no general anesthesia, there's no PO sedation, there's no IV sedation, just pure local tumescent anesthesia, then it takes the BMI and the risk of general anesthesia and the risk of blood clots and all that risk, kind of really minimize it and out of the equation. So the answer to you, most of your weight probably is due from lipedema, lipedema fat. Steph is asking, I have never been diagnosed with lipedema, but I'm at a low weight, but my thighs, knees, and calves never change. Can you do lipo on all three areas at one time? Good question. If the weight doesn't change, thighs, knees, and calves, most likely you have lipedema. And really the way to tell is, common presentation of lipedema is heaviness, swelling, easy bruising, hypermobile joint, resistant to diet and exercise. These are kind of typical symptoms of lipedema. It runs in families. You can see it on your mom's side or your dad's side or in your aunts. Sometimes patients see it in their kids as well. And that's kind of how lipedema presents. It can be stage 1 or it can be advanced stage 2, 3, 4. Most likely you do have lipedema based on if you fit those criteria, right? If you check those criteria. Now the question to your second part of your questions: can you do the ankles all the way up to the thighs? Let's say you want to do like the entire lower extremity, and the answer is no. And part of the reason is because usually patients, they maximize on one of the other. Like in patients here, you would maximize on the amount of numbing medicine that you would inject. because the amount of numbing medicine you would inject is based on the weight, right? So you want to inject as much as you can without overdoing it. You don't want to overdose somebody, right? So you would maximize on that. And like on her, that's what we did on the first one. We did from here all the way here, 360-degree fashion. And then we gave her body a day to absorb all that numbing medicine. So we did her on Tuesday, we gave her Wednesday off, and then on Thursday, we did from here all the way up, and then we did 360 degrees fashion. So I'd say at least you need 2 sessions. Now somebody who has stage 4, let's say, kind of like on the other end of the spectrum, then they will not maximize on the numbing, but they will maximize on the 5 liters. And you still kind of have to do it at least 2 stages on those. If they have more than 10, then they will probably need 3 sessions. If they have less than 10 and they're not maximizing on the numbing, they will need 2 sessions. Very good question, Steph. Lupi is saying, but doesn't cure lymphedema? Again, if the lymphedema is a resultant of lipedema, which is stage 4 lymphedema, LippyLipo, it helps improve it significantly. Now, in terms of using the word cure, even LippyLipo for our patient here is not a cure. So you're keeping the symptoms at bay. There's no, lipedema is like somebody who's born with, like, let's say, high blood pressure. It's not like you take medications or that and then you cure it. Or have somebody who has appendicitis, you take the appendix out, it's cured, Lipedema, basically you're keeping the symptoms at bay, you're minimizing progression, you're improving the quality of life, you're improving the functionality of the patient, but it's not a cure. But to go back to your question, if it's lymphedema coming from lipedema, yes, it helps. If it's just lymphedema by itself, what that means, only one leg has lymphedema all the way down, the treatment is different. You gotta look at bypass surgery plus or minus liposuction. And we don't do those cases. We only specialize in lipedema and lipedema cases that are stage 4 who have an element of lymphedema in them. Steph is saying, can you diagnose someone through photos? Yes, it's actually very simple. If you want to go back, we've done a lot of, every Monday we go at 12 p.m. and we have a live Q&A. If you go back and you do our live Q&A, you're going to be able to know if you have lipedema or not. Because we talk about it, we show pictures, and then the more you see it, the more you're going to be able to know. And if you add your symptoms to it and the vision of how the legs look or how the arms look, you're going to know if you have lipedema or not. So the short answer is yes, because lipedema is a clinical diagnosis. It's based on what you see and based on the symptoms. Claudia is saying, I have lipedema in my legs and always had a large breast. I had a reduction 1 year ago, now it's growing again. I also have lipedema in my breast. That's a great question. That being said, I do know, and I've noticed that with my patients, where patients who do have lipedema, they have dense breasts. So their breasts are more dense. Now the question is, the density in their breast, is that part of it is lipedema or is just a coincidental? I don't think the data is out yet, but if I had to guess, probably there's some element of both. Great point. And I think Dr. Bika and I, we were talking about that in our last live when we were talking about breast density and kind of like all the other stuff. That being said, we're actually going live in January. It's going to have a second session because of all the questions we got asked about hormonal changes, hormonal replacement, menopause, pregnancy, breast, and kind of like thyroid issues and lipedema. So we're going to address all those at that point as well. Carol is saying, thank you so much for taking time to help answer our questions. This process has been an emotional roller coaster, and these answers are providing lots of mental relief. Well, my pleasure. I appreciate you saying that, and I love doing it. And that's how we're gonna win the fight against lipedema, guys. The more we shed the light on it, the more we educate patients, the more we educate healthcare professionals, the more we're gonna be able to solve as many problems as we can together that's related to lipedema. Karen is saying, can you inject fat to breast tissue if you have lipedema to repair a dent? You know, that's a great question. I'm personally, in my humble opinion, I'm not a big proponent of moving lipedema fat cells from one part of the body to the other part of the body. And part of that, we know it's a pathologic fat, you know, it's a diseased fat. And I like to get rid of it. I like to take it out of the body and not relocate it to other areas. We don't know the long-term effect of the lipedema fat cells, what's going to happen on the long run. So I'm very hesitant about moving lipedema fat cells. Now to the breast is less risky, let's say, to the face. Definitely like to the face, because let's say if you move lipedema fat cells to the lower eyelid, we know for the fact that lipedema cells is nodular, fibrous, thick. It's different than regular fat, where it's nice and smooth and kind of more liquid. So God forbid somebody has advancement and now you have like all these nodules in the lower eyelid or the cheek, look at disaster, or in the lips. So I'm very cautious about moving lipedema fat cells out. And sometimes I got that question asked by other plastic surgeons. And they're like, hey, I have patient with lipedema, what's your thoughts on moving the fat? And I was like, because all what I do is lipedema fat cells, so I do get all these questions. And I'm like, hey man, I would just be careful. I just wouldn't jump on it. I'd say do fillers, do other stuff, but move regular fat. You know, if somebody has lipedema in certain areas, regular in other areas, go, and you do need it, like in your case, to the breast, I'll just go after regular fat, because with regular fat, we know what's going to happen. You're probably going to use 30% of that fat, and whatever is left, it's going to act and react as if it's normal, regular fat in your body. If it's lipedema fat, we really don't know the long-term effect, what's going to happen, especially in an area that's more sensitive, like the face area and or the lips. Very good question here. Let's keep going over the list. Another question is that I kind of have through the comments are, will it come back? Would lipedema fat cells come back? And I'll answer that. I see another question here from Zinnia and Carol, and let's go back to those. So, have you seen any correlation between GLP-1 agonist and lipedema? Does it help, or is it completely independent? You know, great question. We are seeing some of our patients are on GLP-1 agonists, and for the audience here, GLP-1 agonists are like the new generation weight loss medications, whether Wegovy or like, you know, depending on kind of this Mounjaro, this Ozempic, this bunch of them. And we know they work very well on regular fats because patients are losing weight. It doesn't shrink lipedema fat cells, it's shrinking regular fat cells. But some patients are actually reporting decrease in inflammation in the lipedema fat cells. So, and talking to multiple other endocrinologists and GYN physicians, they are saying that they're seeing good improvement, at least on the short to long. We don't have like 5-10 years results from that to know what's going to happen on the long run. But short-term results, people are liking the effect of it. From a LippyLipo standpoint, sometimes patients, they kind of get to a point where they lose the regular fat and then they plateau and they are left with the lipedema fat cells. And that's kind of where we go in and really kind of get them to the final outcome. But no long-term studies, but short-term, it's looking promising. So time will tell us. Zinnia is saying, what's your average surgery cost for lower legs stage 2? Link in bio, when you go in on Insta, you kind of submit the information, kind of give you a range of an estimate of kind of like what the prices are gonna be. And that being said, different people are different, because not two patients are the same, depending on what stages they are, how the skin is, what the medical problems patients have. But by going that, at least it gives you a rough estimate. My advice is, it's the value that you're getting. You know, it's kind of like, what's the outcome, what's the consistency, what am I looking for? And kind of like really, I wouldn't look at it as just like cost by itself, I'd look at it cost in relation to value. Because if the value, let's say if this is the cost and the value is here, then this is a great deal, right? But if the cost is here, or let's say the cost is lower, but the value is here, even though it's a lower cost, you're not getting the value you want, so you're not getting a good deal. So you want to look at it, not just cost, both. And the reason I'm saying that, like patients who go and have like a lower cost surgery, not well done, now they come to us, now they have to pay that cost to get that value, and those patients end up losing on both sides. So I'll be very careful when you make that decision. Karen is saying, how do you know where to take regular fat from? Is it stomach area or other areas? That's a good question. So lipedema fat cells, it can be anywhere in the body. I mean, we've seen it in the scalp all the way down to the ankle, really. Now that being said, a well-experienced lipedema specialist or somebody who just does lipedema, you'll be able to tell regular fat from lipedema fat. Not 100%, but like 90% plus. Lipedema fat, it's more thick, fibrous, nodular. You pinch it, it looks like cellulite in nature. It's not cellulite, but it looks like cellulite. It's nodular, easy bruising, swelling. It's heavy. Regular fat doesn't act this way. So if somebody who knows what they're doing, they'll be able to tell where regular fat is, where lipedema fat cells are. Again, they will not be 100%, but at least 90%. Tammy is saying, is asking, what's the recovery time if the person has lupus and fibromyalgia, I guess? Well, that's a great question. And I'll answer that, but let me first address lupus, fibromyalgia, and lipedema. So, lupus or any other autoimmune disease, I can't tell you how many patients with lipedema have autoimmune diseases. Sometimes you see it as thyroids and other stuff, and there is a correlation. Now, what that correlation is, we don't know at this point. But that's all what we do. We've done hundreds and hundreds and hundreds of these cases. Every time I look at patient's chart, I would say about 70% of the times they have other autoimmune problems going on. And the other thing that I see also commonly is fibromyalgia. And fibromyalgia is like, I feel it's the word when the healthcare professional, if they don't know what's going on in a patient, they kind of say it's fibromyalgia. That's been my experience. And the reason I'm saying that, a lot of fibromyalgia diagnoses are actually real problems that are resulting from lipedema. So for example, like your legs are hurting, you're having fibromyalgia. Well, your legs are hurting because you have lipedema, because the lipedema fat cells are inflammatory, then they are inflammating the end of the nerves, and then that's why you're hurting. That's why the plantar aspect of the foot, the bottom of the foot is hurting, is because of the weight of the lipedema and the inflammation of the lipedema. Again, we see plantar fasciitis, kind of like, the bottom of the hoods, you have plantar fasciitis. And then you look, and then we do that lipedema surgery, and then they don't have pain anymore, and now it went away. It's not that they had plantar fasciitis, or they had fibromyalgia, or they have other stuff. They actually had lipedema that was resulting on those symptoms. But if the healthcare professional didn't know about lipedema, they're using other diseases to explain what the patient has, which probably is not correct. So to answer your question, many of our patients have fibromyalgia, have plantar fasciitis, have neurological problems, they do all this testing and, EMGs, this, that, to try to figure out we cannot explain it. And it's actually lipedema. So again, it's just lipedema. We see it. It's not because we're super smart, just because that's what we see it all the time. And we do it, we treat it. I can't tell you how many times, on table, because our patients are fully awake. Let's say I do all the way around the knee, and patients oh my God, it feels so much lighter. I already feel it's better, immediately on table. So those symptoms go away, and the functionality is better. So I'll be very careful about that. Now, to answer your question about the recovery time, what's the recovery time if somebody has fibromyalgia or lupus and all that other stuff? It's like any other recovery time. It's the same. So the first, you're gonna, after the procedure, you're gonna walk out. Every patient after the LiPo, they just walk out. It's just because you're not in a wheelchair, you're not in a, it's just like, because we do it awake, we take our time, we do great work, and just patients, they just walk out. It's been a game changer for us. And then the first 1 to 2 days, like afterwards, you're not feeling anything because the area is numb. Then as the numbing starts to wear off, the first 1 to 2 days, kind of the numbing starts to get, until patients stay on Tylenol and Advil. Most of our patients, they don't even take narcotics. Again, because the area is being very well numb before we treat it. And when you numb the area well and you're not hitting the nerve before it's treated, the nerve does much better afterwards. It thanks you for taking care of it before you start doing the liposuction part. And that's why when you do it awake and you take your time and you do a great job, the recovery is much better than somebody's under general anesthesia. You don't know if that area is numb or not, right? Because they're under general anesthesia, they can't feel anything. And then if you're going with the cannula, you're hitting an area that's not numb, you get more bleeding and you get way more pain afterwards. And then these patients will end up being on pain medications and this and that. So really, if you do a great job on the numbing part and they're fully awake, you don't need that part. So to go back to the point, is after 1 to 2 days, kind of like you start feeling it more, and then you start having swelling. And the swelling peaks around 1 to 2 weeks. And that's where patients are usually freaking out, because they go from here, they look amazing, and to about like where now you have swelling at 2 weeks. Like, oh my God, they would be heavier on the scale. They would look probably worse than they looked at this point, kind of like then started, and then like, oh my God, like, is this normal? And then we'll be, yep, that's very normal. That's kind of the peak of the swelling, and then it's gonna start to go down. Then after 2 to 3 weeks, it starts to go down, and then they start getting more to having these results. So that's a typical recovery. Compression, 6 to 8 weeks, plus more, depending on how much swelling you had beforehand. Somebody who's stage 4 with lipedema, lymphedema, they need more compression than somebody who's stage 1 with tight skin. Somebody who's massive weight loss, they need, because they have more redundant skin, they need more compression than somebody who's not massive weight loss. Yes, Claudia is asking, do you also fix irregularities from older liposuction during your LippyLipo surgery? The answer is yes. We actually, those cases are trickier because we spend a lot of time equalizing and making sure I have a good transition from the area that's not treated to the area that's treated. And these are the areas that are usually more fibrous, because the goal is at the end of each case, what I do is at the end of every single case I do is I take videos and pictures, and I share those pictures immediately at the end of the case with the patient. So the patient knows that day when she goes home, this is how she looked on table. Because if you don't look amazing on table, you're not gonna look amazing a year later. That tells you, like, this is the infrastructure, that tells you how things are gonna look. So kind of like, and this is very, very important. So I wanna make sure that the area where you had lipo and the area that we're doing now is looking as good as it can look. The problem though that we face sometimes is, if the lipo that you had done is really over resected, over lipoed, sometimes the damage is so bad that we cannot even fix it. Or maybe we can improve it 10%, 20%. And if that's the case, we don't take on those cases because the patient's not going to be happy. So we want to make sure that we're able to deliver the result that we're promising, so we are consistent in what we're saying and what we're delivering. And that can become an issue for patients because, like, you know, you're the only one who can help me to get there, but you're not accepting me as a patient. Why is that? And I'm like, because the damage has been so bad that even the best of the best in the world, I cannot get you to where you need to be. If the damage has been under liposuction, it's easier for us. Those we can really help. These are the patients who had liposuction where I'm able to really help them. But if they had like significant over resection, significant scar tissue, significant contour irregularities, it becomes like a skin graft sitting on top of those muscles. And these cases is just very hard to fix. They're like almost unfixable. And these cases, we're very honest about the patients, like they cannot be fixed. So it really depends on your case here. Saying maybe with a fat transfer, yes, you're right. So if over resected and it's mottled and contour irregularities and that looks like skin graft appearance, like a patchy over, then you do need fat transfer, and you might need multiple sessions of fat transfer. And even with that, and that's the point that I was just alluding to, it will not look as good as like our patient here. That's why, like, do your homework, go to the right person, get it right from the get-go. It's much easier on the long run. Great question. Ed is asking, do you do tummy tucks on women? We don't do any other procedures. Everything we do here is related to LippyLipo. We do Lipedema, Liposuction, and we don't do anything else. And we do only one case a day, so we are very, very, very narrow in what we do. And that's why we're like one of the best in the world at it, because that's all what we do. The entire practice is dedicated towards LippyLipo, Lipedema, Liposuction, fully awake, one case a day. That's all what we do. And that's how we're able to deliver amazing results and a great experience for our patients. Tammy is saying, I have had my thyroid removed from Graves' disease and feet problems. There you go. We were just talking about, you're right. I mean, that's, again, lipedema, feet issues, swelling, easy bruising, thyroid problems, autoimmunes. It's a package. It's not like just fat. It's it's hormonal, it's collagen, it's just a bunch. Lipedema is like, it's so much underdiagnosed and we don't know about it. We probably know like 1% of what we need to know about lipedema. Even me. Because every time I see somebody, I learn something new and I'm like, oh my God, and there's no literature about it. There's like nothing about it. No one talks about it. I couldn't agree more, Tammy. I see familiar names here. Shout out to our patients and our colleagues. We've got 5 more minutes to go here. I want to talk about 2 things here. I want to talk about energy devices and why other physicians don't know it. So let's talk about the energy devices and that, because we do get asked that a lot. It's like, how are you getting these amazing results consistently and you're not using a lot of the stuff that other people do? And the reason is everything in life has advantages and disadvantages. The disadvantages of using energy devices such that is the damage to the skin, burns, skin discoloration, and the damage to the lymphatics. And you want to think about it, is the benefit, if there is any benefit, one might argue there might not be even a benefit of that, and you have a lot of side effects and damages. So now the question, why even use it? There's no point. And that's why I have people reaching out to me in the plastic surgery world. It's like, how are you getting that without doing any of the other stuff? The other question is the cost. It's like, oh, we're doing this, and then you're adding the cost. And the problem is there's a lot of marketing. It's like when you go back in history, when you look over the past 10, 15, 20 years in plastic surgery, there were so many machines that come on the market. They come and go. Very few machines who came on the market and they stayed. And I'd say probably 90% plus, they are history now. So what happens to those 90% plus of the machines that came on the market, they were marketed, they were used to treat patients, and now they disappeared. Why did they disappear? Because they didn't work. Or the damage from those machines were worse than the potential advantage that they were getting. And that's kind of where experience comes into play and kind of that. So I would be very careful over new machines, newly marketed things, because the odds are 90% they don't work or they're not going to work. So I'll be very, very careful with that. Unfortunately, there's a huge industry behind it. There's a lot of marketing money behind it. There's a lot of things being pushed to the surgeon to the patient. It's like it's a huge industry. So again, I'm not here to fight the industry. I'm just here to say, from my perspective, if I'm able to get these amazing results consistently with amazing skin and that, then how come what's happening to the other side? The other thing that kind of like, answer here is, let me get all this question and then we'll go to the other point. Actually, Rebecca has a previous question here. I want to make sure I don't miss anyone's question, because the comments, I can answer them next week as well. Let me see. Rebecca saying, I've been diagnosed with lipedema and pretty much time insurance won't cover the surgery. Yeah, I mean, that's an insurance question too. Like, insurances are insurances. They unfortunately, they only take care and they only look after themselves. They don't care about the patient. They don't care about the long-term results. They don't care about the speed to treat the patient. Like, hey, listen, I'm 42 years old. I'm about to hit menopause, or I'm 48, whatever the number is. I really need to go down the route of function. I need to get approval, because otherwise I'm gonna, my hormones are gonna flare, then my lipedema is gonna flare, and then I'm gonna need more surgeries and that. They just don't care. They don't even know. Like that, they don't, like, to you it's a big deal. To them, you're just a number. So that's my problem with insurance. Again, like, I can talk forever, and if you truly care about the patient and if you truly care about yourself, then you gotta figure out a way where you kind of like do it without insurance. Just because it's just, they don't, unfortunately, don't. Then Rebecca saying, told insurance won't cover. Yeah, some insurances, they just don't cover. And again, it all ties in together, guys. This is saying, what age is safe to do any procedure? We operate between 80 to like 70 years old. That's kind of our population. I mean, 18 to 70. That being said, we see most of our patients are like 30, 40 to 65. That's kind of the majority of our population. We fit into that. Lovewell is saying, I missed the beginning of this live. Can we access a rerun? Yes, I save all the lives on the feed, so you can go back and watch them, and watch this one and watch the others. There's tons. These lives, guys, there's tons of information. If you watch all the lives, you're gonna know about lipedema more than 99% of what the entire population knows. Like, just there's so much knowledge and information in these lives that you're gonna know more than your surgeon, more than your primary care, more than your physician. You're gonna know like more than 99%, because we give it. That's the point of it. So watch this one and watch all the other lives. That being said, sometimes with Instagram, it will not save it for some reason. So if it saves it, great. If it doesn't save it, like, so if you can come on these lives, just in case that happens. Okay, Megan is saying, average wait time for skin removal surgery. I know that you no longer do that procedure, but do you have another physician you consult with for referrals for skin removal? Great question, Megan. So I would wait at least 1 year from your LippyLipo to your potential skin removal. And why is that? Because you'll be surprised. The skin with lipedema patients, especially knees down, does very well. Does extremely well. So most of the time, I'll tell you, like, we've done hundreds and hundreds and hundreds of patients. Very few patients who end up needing skin removal. So I would wait at least 1 year, because the skin redrapes very well. That being said, if somebody is massive weight loss or stage 3, 4 and older, then the chances of needing skin removal is much higher than our patient here. Like, our patient, she's in her 50s, mid-50s. She's not going to need skin removal. She's good. She's stage 1, good skin quality. She's going to be fine. Somebody can be 20 years old and they have 100 pounds massive weight loss. Those patients with LippyLipo or without LippyLipo, they're going to need skin removal, because now they have so much skin sitting on that lipedema fat. So it really depends on the patients. But irrespective, you want to give it at least 1 year from your LippyLipo until you start looking into skin removal, from the end of your LippyLipo sessions. The other part of your question is, do you have someone you would recommend for skin removal? My advice for you for skin removal, you want to have it done by the best person you can find in the area that you live in. And why is that? Because when you do a thigh lift or a lower body lift, the chances of complications significantly goes up. Whether skin separation or skin infection or this or that, you want to make sure you live next to that physician. So that, let's say you have a tiny separation, a tiny thing, a tiny infection, then you go to that person, they open it up, they can't treat it. If the surgeon who does the skin resection lives 6 hours by plane, a tiny little thing can become a bigger thing. And the people who live in your area, they're so jealous, and they're not going to take care of you because like, oh, why did you fly to that guy who's 6 hours away and we're here next door? So it creates a lot of problems to patients. So when it comes to skin removal, definitely do it this way. With LippyLipo, the risk is so low. We like almost never see those issues because again, it's different. If you're just doing liposuction awake, LippyLipo, very, 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 very low risk. If you start doing like skin removal, resection, this, that, boom, your risk is here. You want to do that next to home, and you want to do that at the best. And next to home, you want to go to the best person possible for these type of cases. And the mistake that I've seen those being done, never ever do skin resection before you treat all your lipedema fat cells. I can't tell you how many patients they come to me who had thigh lift done and they have lipedema. The problem now is the liposuction is harder because of the scar tissue from the thigh lift, and when I clean all that lipedema fat cells, now they're going to have more skin laxity and then they need another thigh lift. So it's a disaster. You never ever want to do that. You want to do your LippyLipo first, get to the outcome and wait a year and then tighten the skin over that. If you do it the other way around, you make your liposuction hard and you wasted one thigh lift and you took all the risks of a previous thigh lift on a heavier set. It's just a really bad advice. And I see it over and over again. And I think part of the problem, the treating physician just didn't know about lipedema and couldn't diagnose lipedema. So never ever do that, because I've seen that over and over again, and it puts the patient where the patient's like, it makes total sense once we tell them that, and they start feeling bad. But it's not their fault. They went to a specialist, and that specialist didn't know about lipedema. And then one small problems lead to another problem, another bad decision, and you end up in a really bad situation. Megan, I'm very glad you asked this question. The Italian is asking how likely this procedure can lead to a blood clot. Great question. If it's done under general anesthesia, higher chances. When it's done awake, patient is fully awake. There's no IV sedation, there's no PO sedation. They're like us talking now. It's like being at a dentist. It's like numbing, local numbing medicine. Patients are activating the muscles, they're moving around, they're standing up, they're sitting. So the chances of blood clot is like so low. It's just because you don't have, blood clots happens usually with general anesthesia, because the blood pressure goes down on induction, on anesthesia, the veins dilate, and that's when blood clots happen. With awake, you take that out of the equation. Again, it's not zero. We haven't seen it, but like in medicine, it's like less than 1%. That's why you want to have those cases done awake, guys. It's truly a game changer. I used to do them under general anesthesia. And when I shifted to awake, I would never go back. It's a game changer. Less risk, better patient satisfaction. Patients know exactly what I'm doing. They see what I'm doing. They walk out. The risk is lower in every aspect. The risk is better with awake procedure. Rebecca is asking, do you accept insurance We are not in network with insurance. Again, for us, it's about quality. We do 1 case a day. That's all what we do, and it's quality over quantity. My goal is to provide the best outcome possible with the best experience possible consistently every single time. And for me to be able to do that, we just cannot take insurance, because with insurance, it's a numbers game. You gotta do 2, 3, 4 a day to be able to make things work. When you don't take insurance, you don't have to worry about that stuff. You worry about quality. Good question here. A lot of people kind of agreeing. Thank you all. Rebecca is asking, do you treat arms? We do treat arms. You will see most of our posts about legs, because 80% of patients have the lower extremity involved. And 80%, probably about 90% of our work is on legs, just because very few people with arms. Just a few things about arms. If you're getting arms done, make sure 360-degree liposuction is done on the arms and not end of the elbow. You have to make sure you go all the way down to the wrist, because if you have lipedema, pinch along that small finger. Okay, pinch along the pinky finger, and just above the wrist, you're gonna have like dimpling and kind of thickness. That's where lipedema starts with. So if you treat the arm and you don't treat the forearm in 360 degree, you're leaving lipedema behind on the forearm. And as you age, that's gonna become a problem. And I see patients wearing like bands, whether they're wearing watches or rings, they see it more with lipedema. When we treat that forearm, those symptoms go away. So with arms, it's also tricky. You gotta make sure you go below the elbow to get the best outcome possible and to minimize lipedema progression. Sony is saying the only reason why I'm asking, because I'm all the way in Chicago, could I take some photos to you and you could tell me how much would you charge me? All our consultations are virtual. All our patients are actually literally like 99.9% of our patients, they fly to us or they're out of state. So they come to us and we do everything virtual. So it's actually go to the link in bio, submit your information, submit your photos, and then we can take a look at it and take it from there. Arts is saying, what's the best way to get a diagnosis without traveling to you prior to treatment? Go to bio, send the information. Yeah, you guys don't need to come here for the patients come here for the treatment, but everything else is done virtual and kind of like beforehand. Anyhow, all right, guys, that was a great session. Any questions? Feel free to send them, and we'll see you on Mondays at 12 p.m. Central Time.